start blood cells, okay, but they will not be on the exam on Monday. So you'll have additional lab time, or if we're going to do some reviewing the slides after lecture today. And we have our next quiz is Thursday, okay? And we'll be on veins and fetal circulation. All right, so if you have your quiz sheets out, and I put quizzes around the bulb over there, and your extra credit lab credit if you want to pick that up. So question number 1, if you can find it, pour your sheets out. This is quiz 13, and I've been getting some missing, 1 or 2 quizzes for each Monday, Wednesday, or Tuesday, Thursday group that don't have names on them. So please make sure you put your name on your quiz. Venous blood drains from the left posterior intercostal spaces into the left posterior intercostal veins and then into what vessel then? So from the posterior intercostal veins, what are they going to drain into directly? Obviously, they're going to end up in the heart. So hopefully you started diagramming these, drawing them out, and drawing them on your person. Because if you have this on a lecture exam question and you have that drawn out on the blank piece of paper I'll give you, all you have to do is look at it, follow it into the posterior intercostal veins and see what vessel that drains into, instead of trying to draw it in your mind. the lecture exam last year, only the question was about arteries and tracing it to the rectum, and I just flipped them around in the reverse direction and changed them to veins. So if they are incorrect, it's because they're draining into the wrong vessel or coming from the wrong place to get to that vessel.
Do you guys have your book?
Shouldn't have to go any farther than the second step. Figure out which one is right and which ones are wrong. Okay, about 30 more seconds, and then we'll move on to fetal circulation. Okay. So we're going to finish up the blood vessels by looking when closed is called the ligamentum arteriosus. So let's follow the blood flow down the fetal aorta and out to the placenta. On this diagram, they have the umbilical vein bringing blood back to the fetus is red, meaning it's oxygenated, okay? The inferior vena cava, which is deoxygenated, is blue. And then they have it, those two mixing are kind of a purple. They have the superior vena cava coming in. And then the blood flow out of the heart is a purple color, showing it's a mixture, but more deoxygenated than what is leaving the veins. And then as soon as it leaves the vesicular arteries, they show it blue again, which is really it is considered to be deoxygenated, but it's no more deoxygenated than what's already in the aorta, because it's the same oxygen content that's going to go down to the lower extremities of the fetus. Okay, but in comparison to the umbilical vein, it is deoxygenated. It should really be purple here. It shouldn't be that blue, because it's not that low in oxygen when it returns to the placenta. So I'm going to have this up here. This is a better description of the amount of oxygen. It's not as deoxygenated as what's coming back from the capillary of the systemic system, but it's not as oxygenated as what's coming from the placenta. Okay? We're going to start with blood flow from the fetal heart, and it's going to ascend out of the arch of the aorta and down the thoracic and abdominal aortas. And I'm going to come back over this with a purple pattern to show it's not completely oxygenated to the amount that it would be if the fetal lungs were being able to breathe in air. Okay? And then I'll label these in a moment. So we have, this is fetal, and we have the ascending aorta, arch of the aorta, thoracic aorta, abdominal aorta, and we'll put in the diaphragm here, the space for the inferior vena cava, and then the common iliac arteries. All right, they end by dividing to form the internal iliac and external iliac. And it's branches off of the internal iliac that we are interested in. You don't have to be able to identify these on lab, but for lecture I want you to know that the vessels that that come off of the internal iliac are called the inferior vesicular arteries. Okay? We have internal iliac, and we'll just label them vesicular. Vesicular refers to the urinary bladder. Okay? And the branches off of those are the umbilical arteries. So the umbilical arteries don't come directly off of the internal iliac, but come off of vessels that go to the urinary bladder. So these are the umbilical arteries. One off of each. And they're going to travel out of the pelvis up to the baby's umbilical cord, and then out the umbilical cord to the placenta. They are tortuous, meaning they curve back and forth due to their muscular wall layer. And I'm sorry, I can do this with my finger, you probably can't, and open up before they cross each other. Okay, and then they're going to pass into the placenta and be exposed to maternal blood from the fetal via the fetal capillaries. So we have maternal blood from the uterine artery, if you remember, from the mother's internal iliac. identified as the umbilical arteries. And I drew them in red, but I'm going to lay over them in purple again to show that they are not 100% oxygenated. And it's a contradiction in terms, because although they contain the same amount of oxygen as the aorta did, and the same amount of oxygen is going down to the lower extremities, or that is going out to the upper extremities, as soon as it goes into the umbilical arteries, we now call that deoxygenated. Because in comparison to the umbilical vein, it's going to be deoxygenated. So coming down from the aorta is the blood flow that goes into our umbilical arteries. It's the same oxygen content as is going to the rest of the body. That's how the body's getting its oxygen flow. And that's considered to be oxygenated. But when it goes into the umbilical arteries and heads to the placenta to become more oxygenated, we now call this deoxygenated, which is contradictory if we say it's got the same oxygen content as here, but it's considered to carry deoxygenated blood, okay? And the numbers are actually going to be equal. So, I'm going to put deoxygenated there and underline it with a blue. Although it's not as deoxygenated as what's coming back to the heart from the vena cava. Okay, so now, this blood, fetal blood, has picked up oxygen from the placenta that originally entered the mother's body from her own lungs, and it's going to return to the fetal heart. So it's going under low pressure back to the fetal heart. And since it's under low pressure, we're going to call it a vein, but we're going to color it red because it is carrying a high content of oxygen. The highest content of oxygen anywhere in the fetus is coming back to the fetal heart from the placenta. It's also, not only is it going to be high in oxygen, but it's going to receive nutrients from the mother's blood, from her digestive system. So the same nutrients that are available to her cells are going to be in the umbilical vein. So the amino acids and the glucose and vitamins, that the ions, that the minerals that the baby needs for growth are going to be found in the umbilical vein. Now this is considered oxygenated. Okay. So that would be this vessel right here, coming back in the umbilical cord. So when the umbilical cord is cut after an infant is born, they're going to check for the presence of 3 vessels. 2 umbilical arteries, which are smaller in diameter because the muscle wall structure has caused them to constrict, and a single umbilical vein, which is going to be larger in diameter because it's under low pressure, so it has less of a tunica medium than the umbilical arteries. Okay. Now this blood flow is going to head back up to the heart, but in so doing, it's going to pass into the fetal liver. This should be reminiscent of what we just talked about for the portal system, because in our bodies, the nutrient-rich blood coming from the small intestine is going to flow into the portal vein and pass through the liver before it gets back to the heart. Okay? In fact, we have portal vein and hepatic artery both flowing together, carrying blood into the heart. That's very unusual. Normally we have an artery carrying nutrient, oxygen-rich blood into an organ, and the vein carrying deoxygenated blood and more carbon dioxide and waste material out of the organ. But because of the liver's portal system, we have arterial blood with high oxygen and portal venous blood with high nutrient content, both flowing into the liver together. Okay? Replacing the hepatic artery and portal vein traveling together into the liver, we have the umbilical vein. the umbilical vein is both high in oxygen and high in nutrients. What the postnatal portal vein and hepatic artery do together, all right? So when it gets to the liver, some of that can flow through the liver and distribute nutrients to the liver, all right? But most of it will head out of the liver. And it's going to empty into the inferior vena cava. And here's the inferior vena cava, bringing deoxygenated blood from the lower extremities and the pelvis and the abdomen. And it's going to empty up, go into the heart. And so just before it passes out of the abdominal cavity and through the diaphragm, it receives this oxygenated blood from this vessel that's passing through the liver. Okay? So we call this shunt, allows some blood to go to the liver, but the rest of it bypasses it. We call this the ductus venosus. So over here in the diagram, you see this right here. Okay. So now we have oxygenated blood from the placenta mixing with deoxygenated blood from the inferior vena cava. As well, deoxygenated blood from the liver has been added to that because of the hepatic veins. Okay? So now the inferior vena cava is going to be a mixture similar to what we had, so a little higher in oxygen content, similar to what we have in the aorta. And it's going to empty into the right ventricle of the heart. The superior vena cava is completely deoxygenated blood, and it's coming down from the head and the neck region, upper limbs. And the blood from the inferior vena cava is going to pass almost directly through through the foramen ovale into the left atrium. All right, so this would be the foramen ovale right here, between right atrium and left atrium. So we see that over here. Here's the mixed oxygenated and some deoxygenated blood coming through the inferior vena cava and going through the foramen ovale into the left atrium. It comes into the left ventricle. In the meantime, we have deoxygenated blood coming from the superior vena cava. And its angle is going to send it down into the right ventricle. Okay? From the right ventricle, and I apologize if you're trying to draw this while I'm erasing it. From the right ventricle, it's going to pass out of the pulmonary trunk and into the right and left pulmonary arteries. And that's mostly deoxygenated. It may have picked up some of the oxygenated blood from the inferior vena cava, but not much. Okay? So here it is going out the pulmonary trunk to the pulmonary arteries. Now, is the pulmonary system is the right ventricle having to pump harder or less forceful than the left ventricle? When we think about fetal circulation, pumping harder because of the fluid in the alveoli of the lungs that's squeezing the pulmonary capillaries. And because pressure is higher in the pulmonary system, then it's less likely to go into the left lung and more likely to go into this channel that connects the left pulmonary artery to the aorta. So let me draw that over here a little bit larger so you can see that a little bit better. So here we have our pulmonary trunk forming the pulmonary arteries, okay? So pulmonary trunk dividing into left pulmonary artery. Notice it's deoxygenated. And left pulmonary, right pulmonary artery. And then from the left pulmonary artery, because of that high pressure resistance in the lungs, we have this open channel connecting it to the arch of the aorta. And that's the ductus arteriosus. Okay? So if we follow the blood flow now, if you're not dizzy from watching it behind me. We'll start again with the blood leaving the fetal heart and traveling down the aorta to the left and right common iliacs, into the left and right internal iliacs, into the vesicular arteries, and now it's considered to be deoxygenated, okay? It then travels to the placenta, where it picks up oxygen from the maternal blood and returns under lower pressure to the heart as a single umbilical vein. That is as high a content of oxygen as it's going to get, all right? Obtaining it from the mother's blood, not directly from the mother's lung, but from the mother's blood that is in her arterial system. It then flows via the umbilical vein to the liver, where some of it will flow out to the liver and give off nutrients and oxygen to the liver, and the rest will bypass the liver via this structure, the ductus venosus. It will then mix with the completely deoxygenated blood, down to about 40%, not unoxygenated, but deoxygenated. And we have a mixture now that still has enough oxygen to support development of the fetus. And it flows in through the inferior vena cava, and most of it's going to flow at an angle that takes it directly through the foramen ovale into the left atrium. Okay? From there, it's going to flow into the left ventricle and be pumped out the aorta. Deoxygenated blood, similar to our inferior vena cava, is coming down the superior vena cava and into the right ventricle, and being pumped out the right ventricle via the pulmonary trunk to the lungs. Obviously, what's coming back from the lungs is not oxygenated, because the lungs have no gas exchange going on. Their alveoli are filled with fluid, but we need to keep those vessels open. They're not going to automatically develop and grow as soon as the baby is born. We need to continue to send blood flow through them. And then we have that deoxygenated blood returning via to the left atrium and mixing with that. And as a shortcut, because of the high pressure in the lungs, a lot of this blood will not go to the lungs, will bypass the lungs and go into the aorta. So we have two bypass components, both of which are called ductus. So in the liver, where it's bypassing the liver and going into the inferior vena cava, which is a vein, is called the ductus venosus. In the pulmonary artery, where it's bypassing an arterial system and going into the aorta, it's called the ductus arteriosus. Okay? So we have 5 fetal structures that close soon after birth because of the change in pressure, the loss of the umbilical cord, and the change in pressure in the lungs once the infant takes its first breath. That automatically changes and drops significantly the pressure in the pulmonary system when we compare it to the systemic system. So I'm going to stop this and erase, well, I'll I'll leave that up for a moment. If I may erase the board, I want to list the 5 fetal structures, and then what we call them in the after the baby is born, what we call them postnatally. Okay?
Where's the common iliac?
These structures that are in the fetus are still present in you right now to this very day.
Iliac artery.
Like the Springfield Valley, they are closed, okay? But if someone were to take a video of your inside, if you were having abdominal surgery, you'd still be able to find it. You guys have pictures of this? May I erase
I
the
should
board?
just like, no,
Okay.
that is the common
Alright.
iliac arteries. Where's the internal iliac? Do you know which one the internal iliac artery is?
All right, so the first one we're going to put up for the fetus are the 2 umbilical arteries. They are leaving the pelvis and coming up to the belly button, the umbilicus, where the umbilical cord starts. And when the umbilical cord is cut, they're cut as well, okay? And without blood flowing through them, they collapse, but they remain vascular structures, not vascular because blood's not going through them. They remain structures associated with the peritoneum. And they are identified as the medial rather. Umbilical ligaments. Okay? Now, we have medial and median and lateral. So here's the model that I showed you the internal thoracic vessels are. And here's the belly button, umbilicus. We turn it around. We have a single ligament coming up the midline, that would be the median, which comes from the urinary bladder. It used to be open and emptying into the amniotic cavity. So that's in the very midline, that's the median. You don't need to know that one. These 2 are the medial. Those are the remnants of the umbilical arteries. And then the lateral umbilical ligaments are these vessels here. I first showed them to you when we were talking about direct and indirect inguinal hernias. And on either side of these would help determine the inferior epigastrics. You didn't have to know them. You didn't learn them with these vessels. But those form the lateral. So these pair right here that no longer continue to the mother's placenta once the baby's born and the umbilical cord is cut are the 2 medial umbilical ligaments. All right, then coming from the medial, from the umbilicus to the liver, what was the umbilical vein? Is now called the ligamentum teres, which means round ligament. Same as the term, not the same structure, but the same term we use in the female. Why we use teres here and not round ligament, maybe it's just to keep them separate, but translate that, it means round ligament. So we'll be looking at these structures again when we do digestive system at the end of the semester. And we'll be looking at this model again. This is a liver that's way too large for most of us, all right? It fits against the posterior abdominal wall like this. So the stand is attached to the anterior surface of the liver. Inferior vena cava is in the back, all right, goes around it. And if we look on its inferior surface, you can see here where the hepatic artery and the portal vein, hepatic portal vein, empty into the liver, all right, carrying nutrients and oxygenated blood. And this white band right here is the last portion of ligamentum teres, the collapsed umbilical vein that empties into the same region of the liver as the hepatic artery and portal vein, okay? So this would be the ligamentum teres, the remnant, the postnatal remnant of the umbilical vein. Here's the inferior vena cava. So what is this structure that drains that, or bypasses the liver. And the fetus, ductus venosus. And this is the easiest transition structure. This is called ligamentum venosum. And remember, it drains into the inferior vena cava. So if we look at the inferior vena cava on this model, this white band right here, coming around and draining into the inferior vena cava, is the ligamentum venosum. Okay? So it's coming into the inferior vena cava right near the top, about the same location where the hepatic veins would be. It's collapsed, it's no longer carrying blood flow. Once the umbilical cord is cut, there's no source from the placenta, and so this is the postnatal structure of ligamentum venosum. Then we have the foramen ovale, which we talked about on the first day of this unit. And it becomes a fossa ovalis, that oval membrane in the interatrial septum between the right atrium and the left atrium. We saw kind of in here. All right, then the last structure, the ductus arteriosus between the left pulmonary artery and the arch of the aorta, closes and is called the ligamentum arteriosum. Okay, so that would be right there. Fetal structures, and then what we call them after they've closed and they're no longer functional. Setting up the third quiz question so you can see this diagram at the same time. See if that helps you figure out the answers. All right, so which of the following vessels contain oxygenated blood? Mark all that apply. Since I erased the previous diagram in which I had marked that, I thought I'd put it up there with the animation so you can work on that. There are two correct answers. The only thing that's not a vessel would be the foramen ovale, and I don't have it on here. correct answers. Is the umbilical artery one of those? No. Thank you. Okay, does anybody want more time on question number 3? Alright, so let's look at an image of the umbilical vein, and this is kind of small, but again, the two umbilical arteries are going to be of a smaller diameter than the umbilical vein because of the amount of smooth muscle that they have around them. Alright, now if the doctor, either the OB or the pediatrician, finds only one artery, they're not going to be able to do anything about it. It's a little late. Not that they would be able to anyway if they found it earlier, but it can give them a clue to look for other problems that the infant might have. Okay, so let's switch over to blood pressure. We're done with the vessels now. Well, sort of. Blood pressure is still talking about vessels. Another way of thinking of blood pressure is hydrostatic pressure or hydrostatic tension. Hydro referring to water, all right? So this is measured in millimeters of mercury usually, sometimes torr, but usually millimeters of mercury. And as we increase the force pushing on the sides of the vessel walls, blood pressure increases, okay? So that's why we have a systolic pressure and a diastolic pressure when we measure the blood pressure in arteries, because when the heart contracts and ejects the stroke volume, it's going to expand the vessel walls more, and then as that blood moves from one point to the next down the arterial system, those vessels are going to return to their normal size, and pressure is going to drop. It's not going to go completely to zero, but it's going to be less than when the volume of blood was in there more. So we can increase pressure at a particular location by increasing the cardiac output, by increasing the amount of blood that the heart is ejecting. And as we'll see, we can do that with stroke volume, we can do that with heart rate. We can also, pressure is going to also increase if the elasticity of the vessel wall is affected. So if it becomes stiffened through arteriosclerosis, or if it becomes narrowed because of fat deposits, which is atherosclerosis, that can also increase blood pressure. But most causes of elevated blood pressure are unknown, okay? They have some secondary, they're not related to any specific factor. And so we'll move your lab report, the online lab report that I just activated for you guys 20 minutes ago, is due Sunday at 5 to give you some time to use that information to study for your lecture exam, which is a week from tonight, and your lab exam. It's a relatively easy concepts based on what we're talking about tonight compared to all the ions and drugs and stuff that you used on the last one. There are 30 questions and 30 points, all right? In the past, the blood pressure lab has consisted of 2 parts. One, where pulse, kind of a 10-point lab where students measure blood pressure and pulses in lab, and I've incorporated aspects, definitions, and where we find various pulses in that, and then incorporating the physio-X activity. This is the physio-X that came prior to the from activity. It's exercise 5 on the physio-X activity, and we're doing most of them, I think all but one. They don't take very long, they take about maybe 18 minutes each. And so you're looking at the effect of the vessel length, the vessel diameter, the viscosity of the blood, which is what we're going to talk about tonight. So it's over 20. So you get the highest you can score is 30 over 20. Okay? So it's a combined extra credit as well as a regular online lab report. Okay? So we're going to look at some of the factors that I've mentioned and how we adjust them. adjust blood pressure. So here we're looking at two vessels. Pressure, blood flow is being pushed into this vessel at 100 millimeters of mercury. And as it travels out the other end, they're both the same length. It's at 75. So the pressure difference as it travels along the vessel is a loss of 25 millimeters. Here we start at a lower pressure and end at a lower pressure, but we still have the same change. And so what we call blood flow is equal. Remember, blood flows from a high pressure to a low pressure. So how could we change this other than changing the pressure on this end, the stroke volume, the cardiac output? What are two factors that we could do to change the flow out the other end? To slow it down or to speed it up? Or we can change the radius, okay? So if we increase the diameter, is that going to speed up blood flow or slow it down? I got both answers. Going to slow it down if we decrease the size. If we increase the diameter, it's going to decrease the surface that the blood flow interacts with, and that creates friction. So as we'll see, the wider the diameter, the lower the peripheral resistance, the faster the blood flows. Okay? So an increase in diameter means a faster flow, a lower resistance. What about if we shorten the vessel? Is it going to flow faster or slower? Faster. Because that's also decreasing resistance. Okay? So if we have, and I brought it up last night, think of the Magic School Bus episode, if you remember that from your childhood or your kid's childhood or whatever. And one of the Magic School Bus episodes is about playing baseball on a frozen lake. And it's a study of friction, all right? So if you are sliding on the ice rather than sliding on the sand and around the bases, are you going to go farther or less? That's not as far as a regular baseball field. You're sliding into home and it's ice. Farther. Okay, because there's less friction again. So if we have a shorter vessel, then friction has less time to decrease the flow. We have less resistance. All right, so those are some of the factors we're going to look at here. So when we, just getting some home housekeeping out of the way, when we talk about pressure, we have systolic pressure and diastolic pressure. All right, if you recall, systole is when we have the ventricular ejection, and so systolic pressure is going to be the greatest amount when blood is being pushed into the vessels. And blood pressure is always given as two numbers. Anybody remember the vessel where systolic pressure is measured? Is it going to be a vein or an artery? An artery. And it's typically measured at the brachial artery just proximal to the elbow, where it's going to divide into the ulnar and radial arteries. Now you can take your brachial pulse up here, all right, a little easier if you just palpate it by hand. But when we listen to the artery with the stethoscope, it's done just above the crease of the elbow at the brachial artery. What happens is blood flow is keeping the brachial artery open or patent, and then a blood pressure cuff is going to squeeze that. Typically we're not going to have a lab activity today, but we have them if you want to do it, if you've never done one before. So we take a blood pressure cuff and we pump air into it so that it completely collapses the artery. We're not going to have any blood flowing through, right? So we're not going to hear any sounds of blood flowing through the artery when it's not compressed, and we're not going to hear any sounds when it's completely compressed, because there's no turbulence created. Now, it's not completely accepted that the sounds that you hear are due to turbulence, but that's considered to be the most likely cause. And those are called the sounds of Korsakoff. And so we start off first by compressing the vessel with pumping air into the blood pressure cuff. taking the valve and turning it down, turning the pressure down. And you need to practice sometimes to be able to do this smoothly. You don't want to tighten that valve up too tightly before you start to pump, because then you lose time. And as you turn the blood pressure cuff valve down, gradually pressure decreases, and you get a sliver of, not really light, but a sliver of blood flowing through, okay? And the theory is that each time the heart ejects now, and that volume of blood, bolus of blood gets here, it's going to create a turbulence as soon as there's enough space for the blood to flow through. So the first sound that you hear is considered to be systolic pressure, okay? Because that's the force at which the heart is able to push blood through that measured by the blood pressure cuff. As you keep dropping the pressure in the cuff, this space keeps widening. And you still hear that sound. All right, now if there's certain types of heart disease, sometimes it disappears for a while but comes back. And then finally, when the pressure is equal to the pressure when the heart is not pumping any blood through, that sound disappears because there's no turbulence created, okay? So that last sound that you hear is typically the value for the diastolic pressure. Now, as you become more comfortable taking blood pressure, you don't even have to listen to it. You can see the needle start to bounce, okay? And anybody know what the valve is called that has the measurements on it that measure pressure? It's a long word. Sphygmomanometer. Okay, or if you want to, sphygmomanometer, if you want to remember how to spell it. And I actually looked up what these words mean. So sphygmo refers to, or just sphig refers to pulse. Mano refers to thin. And then of course meter is measurement. I don't know where the thin comes from, but this was first determined by the Kortkov found, who was a Russian physician, in like 1905, 1910, something like that, when he first used a stethoscope on it. You don't have to use a stethoscope, you can do it by palpation. All right, if you just have a cuff and you don't have a stethoscope, you can feel the pulse and when it disappears, but that's a little bit more difficult. This is a question on the lab report, by the way. And I actually have a link to hearing the sounds. There's a question about the sounds of Kortkov. And there's a link that you can listen to it, but you'll need to turn your voice. It says use headphones, but I heard it on my computer without them. Just turn the volume up a bit. All right, so if we take systolic pressure and 120 over 80 used to be considered the midline of normal. The range, so anything over 140 over 90 was considered high blood pressure, and anything less than 90 over 60 was considered low blood pressure. And the average right in the middle was 120 over 80. And currently now that's considered to be the high level of pre-hypertensive. So most medical specialists don't want you to get over 120 over 80 without doing exercise or diet change to keep it from going any higher than that. All right, so I'm going to use a number because of the math that I'm going to have to do. I'm going to use a number slightly different. I'm going to make this 120, and I'm going to make this 90. A little high on the diastolic end, okay? So if we were to do an average, most of you know how to take averages. We add two numbers together, or any number of numbers together, and divide by the number of the numbers. Yeah, 5 numbers or 2 numbers. So here we have 2 numbers. And 120 plus 90 is equal to 210. And we divide by 2. So our average is going to be 105. Okay? So that would be the average blood pressure between diastolic and systolic. millimeters of mercury. Now, if we look at this graph, obviously the pressure is highest where the blood is coming from, in the heart, and pressure drops as we get to the vena cava because blood flows due to a pressure gradient. So it has to be going from a higher to a lower to a lower to a lower to a lower, and when it comes back to the heart, that has to be the lowest, or it wouldn't return to the heart. Okay? But you'll notice this line, here's average right here. This line is slightly less than average, and that's called the mean. Anybody know the difference between average and mean? Average is the equal distance, the value that's equally between all of the numbers summed together. The mean is which value appears the most often. All right, so if we were to measure blood pressure, every half second, is the heart in systole longer or in diastole longer, typically? Think about the ECG strips that you ran last week. If your heart rate is 60 beats a minute, would you be in a QRS lasting for a whole second? No. So the heart, unless you've got a 210 beats per minute, the heart's going to be in diastole longer because it's filling. It's going to be in diastole longer than it is in systole. So the values of the blood pressure are going to be lower more than they're going to be in a higher range. Does that make sense? All right, because if we look at our heart rate on the ECG, we see something that looks like this. So we're in ventricular filling and a lower pressure for a longer period of time. So to determine mean arterial pressure, or MAP, we use a formula that's not too difficult. So mean arterial pressure, we take the diastolic pressure and add it to 1/3 of the pulse pressure. Pulse pressure is a weird term, but it's the difference between these two. Okay? So mean arterial pressure is equal to diastolic pressure plus pulse pressure divided by 3. And I'm going to put parentheses around that. We don't add diastolic to pulse and then divide the whole thing by 3. Okay? So you take your diastolic pressure, which in this case was 90. Okay? And the pulse pressure is 120 minus 90, which is 30, which is why I wanted something divisible easily by 3. So 30 divided by 3 is 10. So my mean arterial pressure is going to be 100 instead of 105. Okay? So we take diastolic, take the difference between the two divided by 3 and add it to diastolic. And that gives us our mean arterial pressure.
Pressure equal to the average.
Pardon?
Pulse pressure equal to average pressure.
It will depend on what the numbers are. It's going to be relatively close, but it can be, depending on the difference between systolic and diastolic, it can vary on how close it is. But it will never be more, it will never be equal to or more than the average. Unless the two numbers are the same, and that's not going to happen. Okay, so here's an opportunity to do some math. Hopefully you can do this in your head. So provide the mean arterial pressure from the following. Diastolic pressure is 110. Systolic pressure is 170, and I shouldn't have to tell you which is which because diastolic is always the lowest. And this is relatively high, all right? We don't want to see our diastolic pressure more than 80 usually. pressure be?
It's 130, right?
Come on, ladies.
140. I guess I'm gonna try it.
2 divided by 2 is 1, and 8 divided by 2 is 4.
Twice.
Okay? All right, let's move on into the factors now that are going to change blood pressure. So we're going to look at characteristics of the blood vessels that affect blood pressure, and then the very end we're going to look at three hormones.
How'd you get 140?
We'll discuss them in more detail when we actually get to the urinary system, but we'll look at their general effects on blood volume.
Right? It's 170.
Okay, does anybody want more time on the
170
map for
plus
this?
110?
Yeah.
This is something you'll have to do for the lab exam on Tuesday. Without a calculator.
Oh, wait, so we're not figuring out the mean.
No.
Wait, yeah, the mean. Isn't it?
I use numbers that are easily divisible by 3.
Right. I was.
It's 110 plus.
I did for myself up there. You can use your fingers.
You make it easy?
Okay.
You're right.
Did you switch them? Because she had it.
All right, so factors affecting blood pressure, cardiac output.
What number was it?
This is related to blood volume, but in this case here, blood volume is going to be affected by the kidneys and how much you drink and how much you pee and that type of thing, okay? Cardiac output is determined by heart rate and stroke volume, as we've seen already. And then finally, we bring in our blood vessels because they affect peripheral resistance by their diameter, by their length, and by the thickness of the blood that they transport. So, then we will review autorhythmic cells and so on again. So this is another opportunity to review those. So cardiac output, what's the formula for cardiac output? Heart rate times stroke volume. So cardiac output is the amount of blood that one ventricle pumps out of the heart in 1 minute. It should be equal to the amount of blood that the other ventricle pumps out too, okay, even though it's under a different force. So if the heart rate is 70 and the stroke volume is 70, we said our cardiac output was 4,900 mils per minute. Okay, because our heart rate is beats per minute and stroke volume is mils per stroke. Heart rate is the number of strokes in a minute, so we multiply the two. All right, so we had this slide a few days ago. So it's one ventricle we're talking about, not the sum, and the two ventricles should be equal. So if we increase heart rate, we're going to increase stroke volume if everything else stays the same. And if we increase heart rate, we're going to increase cardiac output. And if we increase stroke volume and we keep the same heart rate, everything stays the same. Okay? So if I ask you a question like this, I don't want you to assume that the body is going to compensate with an increased stroke volume by lowering the heart rate. It will eventually, all right? But I don't want down the line effects. I want the immediate effect. So if we increase heart rate, cardiac output's going to go up. If we decrease stroke volume, cardiac output's going to go down. Okay? And if I want compensation, I'll say specifically what would be the compensation for that to maintain a normal cardiac output or blood flow. All right, so heart rate is affected by the autonomic nervous system, as we already saw, with the sympathetic and parasympathetic. All right. So vagus nerve is releasing acetylcholine and binding to postganglionic neurons. Here's our brachiocephalic vein forming the superior vena cava, and the yellow one here is showing the vagus nerve. There would be another vagus nerve coming the other side. And it's releasing, the postganglionic neuron is releasing acetylcholine that is binding to receptors on the sinoatrial and atrioventricular nodes, but not on the ventricular cardiac contractile cells, remember. So we're affecting heart rate by the production of inhibitory alpha subunits that decrease the the formation of cyclic AMP by inhibiting adenylate cyclase. You've heard all this before, so hopefully it's triggering memories. All right, so without enough cyclic AMP, not as many funny channels for sodium open, and they open later. All right, so we see as that effect then, this red line down here, our graded potential for our autorhythmic cell action potential is going to take longer. In addition, without the cyclic AMP, our transient calcium channels, fewer of them open. So we're adding less calcium to that gradient. And then to make things take even longer, our gamma and beta G proteins are going to open potassium channels. So we're getting fewer positive ions in through our funny channels and our calcium channels, and we're losing positive ions by the gamma and beta components of the subunits letting potassium out. So with less positive ions coming in and more positive ions going, it takes longer to reach our action potential and the heart rate is slow. Okay? Then when we look at the sympathetic nervous system, we have a faster heart rate because the beta-1 receptors are binding norepinephrine, and that increases the activation of adenylate cyclase, increases the amount of cyclic AMP, which causes the funny channels to open earlier and more of them. And protein kinase opens more of our transient calcium. So it takes us less time to reach our graded potential because we're adding more positive to the ions to the cell, more sodium, more calcium over a shorter period of time. So we get to our threshold more rapidly. Okay, so that's going to affect heart rate. We talked about thyroid hormone also increasing heart rate, okay, by activating genes to make more of the proteins that allow positive ions in. You don't have to worry about estrogen or cortisol, which is the thyroid, the only one I mentioned. Ions will change heart rate. You did that with the cardiophysiology, all right? And we have too much potassium, heart rate slows down, we get into this sinusoidal rhythm, and sodium can affect heart rate as well. So heart rate is going to change, affect cardiac output. So is stroke volume. Those are the two factors that we see with cardiac output. And we had three factors affecting cardiac output. We had preload, and we had contractility, and we had afterload. Okay, so preload is how much blood is coming into the ventricles, stretching out the volume, and the heart responds by the muscles contracting back to their original shape. This is where we talked about venous return, increased exercise, increased fluid volume, increased cardiac output even, because it has to come back eventually. It's going to all increase venous return. Then we had contractility, and that I want you to think of contractility as directly related to calcium ions. So the more calcium ions we have in the cardiac ventricular contractile cells, the more binding sites on actin are available, and the greater number of myosin is going to pull on the actin, and we have a greater contractility. We usually see a decrease in end-systolic volume, the amount of blood left in the heart. The Frank-Starling law is just saying we come back to our normal. If we have a greater end-diastolic volume, we come back to a normal end-systolic volume with Frank-Starling law. Contractility means that if we have a normal or greater volume, we come back, we eject more out of the heart, we have a lower end-systolic volume because we're pumping more out. Okay? So now we're going to look at, well, we know that blood volume stretches the walls, so it's just going to put more pressure the greater the volume. And now let's look at peripheral resistance. Those are the three new things that we introduced briefly at the very beginning. So vessel diameter is often described as the radius. Okay, the radius is actually half the diameter. And so what are the blood vessels that are most important in changing their radius, either by constriction or dilation, and affecting blood pressure? No, you're close. Arterioles. So why arterioles rather than arteries? More of them. Therefore we have more surface. Okay, so let me draw draw another simple diagram. When we talked about at any point in the circulation, if we have the volume of the aorta, and then we get to the arterioles, we're going to have more arterioles than a single aorta, right? So we add up the volume of all the arterioles, it's going to equal the volume of the aorta. But which one has more surface area added up? The arterioles do, okay? Now capillaries would have even more, but why don't capillaries contribute to blood pressure? They don't have any muscle, and veins have not as much muscle as the arterioles for their diameter. So arterioles have the greatest number and surface area to be affected by the change in constriction or dilation. So this is why these are most important in changing peripheral resistance, by changing their vessel diameter. So one of the factors that we think about this is, when we think about peripheral resistance, is identified as laminar flow, meaning in layers. So a greater proportion of the volume of the blood in this vessel is going to be in laminar flow, meaning it's not interacting with the size of the vessel, okay? So if you think about going down a water chute at a water parkway, and you're just slipping straight down versus bouncing against the walls and the roof and every which way, you're going to go faster if you just go straight down with the water flow. Whereas if you're bouncing back and forth all over the walls, that's going to slow you down. So if we have blood cells and proteins interacting with the wall here, that's going to increase turbulence, and that's going to slow them down. And that's more likely to happen here. A greater proportion of the volume of the blood is going to interact with the surface area. That's why increased surface area increases peripheral resistance. Okay? So the smaller the diameter, the more the resistance, the slower the blood flow. The slower the blood flow, the more it starts to back up and push out the diameter of the vessel walls. So you can either describe it as flow or resistance. Both of those are going to be a factor of pressure, and it's equal to the radius to the fourth power. So it's inversely proportional, okay? Or not inversely proportional, but as we decrease the diameter of the vessel, the resistance goes up proportionally to the decrease in the diameter of the vessel. So the resistance is going to increase as the diameter becomes less. Okay? So you don't have to memorize this formula, but I'll illustrate it with this next image. So here we have gravitational pressure is pushing the fluid out the tubes. Okay? This tube has a radius of 1, meaning the diameter would be 2. All right, but you can go by the radius. This has a radius of 2. The flow here, all right, is a factor of 6 to the fourth power. So we take the radius times 2 is 4, times 2 again is 8, times 2 again is 16. All right, so this has a greater volume in the same time than this one does, because again, more laminar flow. This is not slowed down as much by the interaction, the turbulence created by bumping against the surface wall. Okay? So flow increases with increasing radii. Resistance increases with decreasing radii. Okay? So one of the things that your body does when you stand up, what happens to gravitational force in your blood? Gravity's going to pull the blood back down to your lower extremities, and what's already there is going to have a greater difficulty of time of moving back up to your head. So to keep you from fainting when you stand up, orthostatic hypotension, is the blood vessels in your lower extremities constrict. Okay? What what we call tone. It increases tone and moves the blood up and helps to maintain blood pressure against the blood flow that's wanting to flow down to your lower extremities. All right, so our last question, we're not done I'm not done the lecture, but our last question here. So mark all that apply. Which of these is a true statement? Blood flow, that's the rate, mils per minute of blood flowing through a vessel, is directly proportional to the length of the vessel. So what this is saying is, will blood flow faster if the length of the blood vessel gets longer? Then it's inversely proportional to the viscosity of the blood. We haven't talked about that yet, so I'll come back to this question. I want to use it as a lead into what we're going to talk about. So what we're saying here is blood will flow more slowly as the viscosity or the thickness of the blood increases. That's inversely proportional, okay? So one goes down while the other one goes up. And then the last one is saying blood flow is directly proportional to the radius of the vessel wall. So blood flow goes up when the radius increases, the diameter gets bigger, or blood flow goes down as the diameter gets smaller. That's what we mean by directly proportional, okay? So it's moving in the same direction. So directly proportional means blood flow increases as the vessel length increases, or blood flow decreases as the thickness of the blood increases. And then the third one is blood flow decreases as the radius decreases, or vice versa, increases as the radius increases. Do they both go in the same direction? That's directly proportional, or do they, one goes up while the other one goes down?
And you said flow is the same as resistance.
Yeah.
So resistance, okay.
Yeah, because increased resistance is going to decrease flow.
Okay.
So you can change that to resistance, and you can say resistance. Well, they're related, but you could say they're the same thing. So, yeah, it changes the relationship. Yeah, it's not that you can't interchange the words. They're certainly related, but as peripheral resistance goes up, blood flow is going to go down. So if something causes resistance to go up, the blood flow is not going to go up. So for this question, don't interchange blood flow and resistance. If you said it properly, you could say resistance decreases as the length of a blood vessel decreases.
Yes.
Okay? Or resistance decreases as viscosity decreases or increases. But just to keep it straight, just use blood flow. Okay, we'll come back to this after we've talked about those factors, okay? I want to give you an incentive to listen a little more closely. All right, so these four tubes, all are going to have 100 millimeters of mercury pushing blood through the tube, okay? If you take systolic pressure, it's going to be 100. Notice the diameter of the vessel. Notice that we have different lengths, okay? So resistance, we have radius, viscosity. We haven't talked about the viscosity. We're just looking at length and diameter. So which tube would have blood flowing through it the fastest? So you're going to have, is it going to be the large diameter or the small diameter? Large diameter. So it'd be two of the middle, right? And then would it be the longest one or the shortest one? The shortest one, okay? So this would have blood flowing through it the fastest because its resistance is the lowest, okay? Then which one would have blood flowing through it thus most slowly? The bottom one, because it has the smallest diameter and the longest length. Now, interestingly enough, when we get to respiratory system, we're going to talk about airflow as the more narrow the airway, the more resistance there is for air to flow into or out of your lungs. The longer the airway, if you're on a ventilating tube, so if you're trying to breathe through a really long straw, you've got more resistance, air is banging against the sides of that straw more, all right? The only thing that really doesn't change much is viscosity, unless the air is saturated with water or it's very, very, very dense with smog, okay? But diameter of airway and length of airway are factors in airflow in your lungs as well. All right, so looking at viscosity, so we talked about radius, all right? And the smaller radius is going to increase peripheral resistance because we have more of the proportion of the volume is in contact with the surface, and that increases friction for blood flowing through, okay? So a smaller radius is going to cause more peripheral resistance than a larger radius. For the same reason of surface area, a longer length blood vessel is going to have a more total resistance than a shorter length vessel. Now, we add vessels to our body wall, our body system, when we increase our body tissues, especially adipose tissue. Adipose tissue has a high vascularity. And so there's increased peripheral resistance with increased weight gain. Which would you be able to change the most quickly? Diameter or vessel length? Diameter, you can do that almost instantaneously with autonomic nerve responses. Sympathetic nervous system is what constricts or dilates your arterioles. You couldn't lose weight, you couldn't lose 20 pounds in 5 minutes, okay? Unless you had a limb amputated. That's about the only way to lose blood vessel length, total length in your body, and even that wouldn't be as fast as vascular changes. Okay, viscosity has to do with thickness. And as I told my class last night, I typically use black bean soup as an example. So how thick would your soup be if you used 4 cups of cooked beans for 1 cup of broth? Versus 4 cups of broth and 1 cup of cooked beans. You wouldn't be able to stand a fork up in that second one, okay? You need a spoon to eat it instead of a fork. So if we think about viscosity of blood, it's a proportion between the fluid of the blood, the plasma of the blood, and the blood cells. Now, to some extent, the proteins that are in there as well. But we have a large number of cells, especially red blood cells, white blood cells, and platelets. So if you get dehydrated, you're out in the desert, or you're in Colorado where the humidity is about half of what it is here, and we think California is dry. 5 minutes after I take a shower, my fingers, I have to go get hand cream because they're feeling all dry. And so if you get dehydrated, you haven't gained any more blood cells, but your hematocrit, when we spin down the cells, they're going to form a greater proportion of the volume of blood than if you had sufficient fluid. And that's without even gaining cells, okay? What's the way that, even if you were hydrated, what's the way that you could increase the number of blood cells in your body? Go live at a higher elevation. All right, more quickly even than that, because that would take about 3 weeks. Yeah, doping, blood doping. So, prior to an athletic event, you need more red blood cells to transport oxygen. Take some from the refrigerator that you banked and spun down as packed blood cells and inject them into your veins, and you're going to have more oxygen, but you're also going to have a higher viscosity, and what's going to happen to resistance? It's going to go up. Your viscosity is going to be your blood, maybe the exaggeration to call it sludge, but if you can imagine trying to pump sludge through your body. So there's a range there where you don't want to get too thick of blood for the advantage that you have of the oxygen transport, because then your heart's going to have to do that much more work, okay? So we can add cells through doping or through living in higher elevation. We can lose fluids through dehydration. What's another way we can lose fluids? Going to the bathroom, okay? So that's what I want to finish up with, is looking at 3 ways in which the body hormones affect fluid loss. 2 of them are going to cause us to increase fluid retention, and 1 is going to increase fluid loss. So We've talked about congestive heart failure, and treatment for that is usually to increase force of contraction, but also to decrease afterload. Remember what afterload was? Afterload, if you're going to, let's say you have a big heavy box that you're pushing along rollers that are on the road. Once the rollers start rolling, that's going to decrease your friction, right? But you have to push enough to get that box moving. So when the ventricles contract, they have to overcome the blood that's already in the aorta before they can put more blood in there, and that's afterload, okay? So the body, we can increase the force of contraction with somebody with congestive heart failure by increasing calcium to their ventricles, using drugs that increase calcium. We can also decrease the afterload by eliminating fluid via diuretics. All right, so having them watch their intake and output, restrict salt if that's a problem for them. All right, so I'm going to go through the 3 hormones. I want you to know what organ makes them, distributes them, and where they have their effect. Okay? To make it easy, all 3 of them are going to affect the kidneys. As far as detailed mechanism, we'll look at that when we get to the urinary system. And I don't want you to get the wrong idea here. That the hypothalamus actually makes antidiuretic hormone, but it's released from the posterior pituitary, as we learned in our first unit. So antidiuretic hormone, ADH, has its function in its name. It's an antidiuretic. It's going to cause the body to put out less fluid in the urine. Okay? It's made by the hypothalamus. The neurons, the cell bodies of the neurons of the hypothalamus are going to release it from the posterior pituitary. Remember, we have these cell bodies in the hypothalamus, and then they come down to the posterior pituitary, and ADH is actually released into the bloodstream from the posterior pituitary. So this releases it. This synthesizes it. Okay? And then it travels in the blood to the kidney tubules, where we have absorbed fluids, and we've returned most of all the glucose and amino acids and most of the sodium back. And around these tubules of filtered blood, we have a lot of sodium ions. How they get there we'll talk about when we get to the urinary system. This is not blood and it's not urine yet because we haven't finished modifying what's in it and what's not, so we call it filtrate. If your blood volume is low, and that's detected by sodium sensors in the hypothalamus, it will release antidiuretic hormone, which will come to these cells and insert into them water channels.
Is that the kidney?
Yeah, this is another kidney. A very simple diagram with the kidney. So as the filtrate flows down these tubules, if these channels are in place, the high concentration of sodium outside is going to have an osmotic effect, and water is going to move from its high concentration to its low concentration. And water is going to flow out of the filtrate back into the extracellular spaces and back into the blood. Okay? So we're going to decrease urine output. And increase blood volume. This is like putting sugar on strawberries if you're making strawberry shortcake. The sugar outside the strawberries draws water from inside the strawberry cells, and if you leave it too long, strawberries look kind of yucky. You have lots of strawberry juice. Okay? So by putting in these water channels, now if you drunk 5 gallons of water yesterday, you're not gonna make any ADH. These water channels are gonna not be in the cell, and you're gonna have a high urine output of almost clear urine, okay? But if you've only gotten water from the food that you've eaten and you haven't drunk any water in the last 2 days, then you're gonna have water channels inserted in here because of ADH. You're gonna reabsorb a lot of water, your urine output will decrease and become very dark in color because it gets highly concentrated. So, we increase water reabsorption, which increases blood volume. An increase in blood volume is going to increase venous return. That's going to increase our end-diastolic volume. We've talked about this already. The cardiac cycle, which is going to increase stroke volume. As we saw in the earlier slide, we're going to increase cardiac output. And as we increase cardiac output, blood pressure goes up. Okay? The reason this happens in the kidneys is because the kidneys need an adequate pressure force for filtration. Your pressure in the blood is too low, then it doesn't get pushed across the filtration membrane of the kidney. So the kidney is quite invested in having an adequate pressure. Too high a pressure damages it, but it needs an adequate pressure to filter it. Okay, so antidiuretic hormone made in the hypothalamus, released by the posterior pituitary, works in the kidneys. Okay, a little more cellular detail we'll cover in the urinary system. All right. Second hormone, if you're ready, is aldosterone. That comes from the adrenal gland. It also goes to the kidneys. Not very far to go, but it goes through the urine, the cardiovascular system. It does work with sodium ions, but notice here the sodium ions were already outstripped in the extracellular fluid and just osmotically attracted the water. Okay. Aldosterone works slightly differently. It moves the sodium. So we have sodium channels, sodium pumps, some exchange with potassium, some exchange with hydrogen, so I'm not going to put that in there. But it's going to move potassium out of the filtrate. And as potassium moves, as sodium moves, what follows it passively? Water. Okay? So aldosterone works by moving sodium. Sorry about the potassium. Moves by working sodium, and then water follows passively. So when we get to the urinary system, we'll discuss how these two hormones affect the osmolality of the blood differently, but we're not going to worry about that. We still have the same effect. More water is reabsorbed back into the body, and we have a decrease in urine output again, and an increase in blood volume and venous return. Go back over here. If there's an increase in venous return, there's an increase in end-diastolic volume. That's going to stretch out the ventricles, and Frank starting off says we have an increase in stroke volume, which is going to increase cardiac output, and that's going to increase blood pressure. Okay? So these are the two of the three molecules that function to increase blood pressure by increasing overall total blood volume. By the way, what would happen to our viscosity? It's going to go down or go up? It's going to go down, meaning peripheral resistance goes down as well, okay? But the blood volume is stretching the blood vessel walls, and so we see an end result is an increase in blood pressure. Okay, last one comes from the heart. Did you know the heart was an endocrine organ? I mentioned it very briefly at the beginning, but it is on every organ in the body is an endocrine organ. So this is called atrionatriuretic peptide or protein or hormone. And it's released by the muscle cells of the atria when the atria are overstretched. So too much blood is returning to the heart and causes the atria to stretch, especially while the AV valves are closed, because usually that blood goes into the ventricles. But when the AV valves are closed and we have blood returning constantly to the heart, it just can't go into the ventricles yet. So to stretch those atrial walls. And they function then to release atrial natriuretic peptide. So the heart is our organ. By the way, that's where we get our symbol for sodium. Natriuretic means refers to sodium, so Na is our abbreviation for the element of sodium. And it works on the kidney, just like the previous two, but it's going to do the opposite of aldosterone. It's going to shut down these sodium pumps. And so instead of taking sodium and returning it to the body, the sodium stays in the blood. And so stays in the filtrate. And it doesn't go to the body. So we'll put an X here. And we'll put an X here. So it blocks that. So we increase urine output because the water is staying in the filtrate. And we decrease blood volume because we're increasing urine output. We're getting rid of urine, water. So everything here now is a decrease. With the decrease of sodium in the blood, we have a decrease of water. Means there's a decrease of blood volume. Less blood coming back to the heart means a decrease in venous return, which means stroke volume is lower, and therefore cardiac output is lower, and therefore decrease of blood pressure. Okay? All right. So we went a little longer than I normally do with the break, but it wasn't that much to cover with the hormones. What I want to do next, you have the rest of lab time to study the blood vessels, the veins, and fetal circulation for a quiz on Thursday, and of course the exam on Tuesday. But after break, I want to go through a series of slides and do some reviews with you about the physiology and about blood vessels. So kind of a throw up questions and have you tell me what's the vessel that branches off of the internal thoracic, or where does this ion go, or something like that. We'll do that for about 20 minutes or so after break. Okay? So why don't you take about a 15-minute break? I can't see where the... So about 7:30, and we'll do that with you. And then we'll finish it on Wednesday. Thursday. I'm not going to do all of it tonight. We'll do some more on Thursday, and we'll do some blood tracing on Thursday after we finish studying for the quiz.